Our next speaker is Dr. Julie Eisengart, who is known to all of us. She is an incredible neurocognitive psychologist and researcher working at the University of Minnesota. We are lucky to say that she is a member of not only our scientific advisory board, but also the incoming chair. Welcome, Julie, and thank you.
So what am I doing next? Just going down? Oh. I think you have to enable the content.
We are frozen.
Frozen.
Third time's the charm. I don't know why it came up first, I don't know the others.
This one is tough. Yay. You were good luck. Thank you. Okay. That took Matthew 3 minutes and 59 seconds. Nice job. Okay, so I'm a pediatric neuropsychologist from Minnesota, as Matthew said. So happy to be here. Today, I'm going to be talking about abilities and priorities in terms of the community's priorities and the kinds of things that we are evolving in our ability to measure when it comes to functioning of people touched by MPS. And, I was really fascinated when Dr. Munzer, during the first session, said when he got up here, he wasn't really able to talk about any treatments. And I think that in the past, we talked so much about cognitive and IQ because that's a really, it's shown to be a pretty good, it aligns with disease process and can kind of indicate how disease is progressing really well. And as our times have evolved and as the community voice has gotten louder and louder and has really courageously educated policy and certainly science, we've been able to, now that we sort of have a lot of cognitive, sort of the IQ pretty well characterized in some of the MPSs, now we have this ability to expand, and it's really important to do so. So here are my conflicts. Okay, so I'm going to touch upon the considerations that we have for how MPS affects cognition. I'll talk about measuring function in MPS, and then really get into expanding the lens of function. So I've presented this before, but certainly we know that the MPSs that involve cognitive decline, the sort of steep visible cognitive decline in a relatively short time frame, certainly involve disease process on the brain. But there are these other really important pieces of MPS that affect how people perform on cognitive tests, how they certainly perform in daily life. And when we're considering our measurements of people, whether it's on IQ tests or on other tests, we take into account the other pieces of MPS that affect how that person's performing. Disrupted sleep is a really good example. And the grace we tend to give ourselves when we haven't gotten a good night's sleep. And then we have to think about people who are diagnosed with MPS, the disrupted sleep, and how that affects mood, behavior, concentration, and then the caregivers who are also experiencing disrupted sleep as they care for their person. So that's an example. I've listed a lot of these out, but in the interest of time, I'll probably get into them later in the talk. As for measurement of function, this is that hypothetical illustration, hypothetical in terms of it's a hypothetical disease, but this is how we've classically measured cognition. So in this illustration, the x-axis is the chronological age, and then this y-axis is the mental age, or sort of how the person is functioning in terms of what would the age equivalent be. This line here is the curve of unaffected development, healthy, typical development, where essentially the chronological age and the mental age are one and the same. We have this vector of disease effect, which is the neurodegenerative process affecting the person. So in this period here, we know that the disease is happening, but it hasn't accumulated to cause any visible clinical effects. So what we see is that the affected person is really still just hugging this normal curve. This is one of the reasons that newborn screening is so important, because this time is the time when the disease is invisible and nobody really is very suspicious. Now, there's also this period here when the disease starts to affect the person and begins to pull their developmental curve away. But because it's still upward facing, it means they're still learning. They're just not learning as quickly as their peers. So this is a time when their parent concerns are either overlooked, or there's encouragement for watchful waiting. They're still learning and nobody suspects anything. So when disease is intercepted here, if there is an effective therapy while this learning process is still going, then Many times there can be resuming of development, and you'll see that that developmental trajectory I put in there, I purposefully made it non-parallel to unaffected healthy development, because we expect the learning to be sort of on the neurodiversity spectrum. So maybe learning differently, maybe learning more slowly. And so there might be this gap between the affected person and peers. If, on the other hand, an affected intervention is applied when there's already been a regression in skills, that's when it's a little bit more uncertain as to what that trajectory will look like. Will it go flat and sort of maintain the person where they were, or will it not actually have an impact, and will there be a continued decline? At the beginning of this talk, I had said we've characterized a few of the MPS types in terms of, what does decline look like? For all of them, they're sort of drawn in a similar way to that hypothetical illustration, where really, being nice to the other side of the room, really they're all sort of these curves of development, some slowing in development, and then a decline. And when that occurs is different for the different MPS types. So when we're thinking about testing people who have MPS, we think about all kinds of things once we're in that testing room. One of the things we think about is how MPS is affecting this person's ability to engage in our testing. Are there physical limitations that make it harder to, reach test pieces across the table? What do we need to do to rise to the needs of the individual who has MPS and make our room fit them instead of making them fit our room? We also think about, attention spans, behavioral needs, and then we think about the effects of other appointments on test engagement. When we were seeing people in our clinic during the height of COVID, a lot of the children were coming in very worried we were going to be, swabbing up their noses, those horrible swabs that we used to do up the nose. We think about things like recent sedation, surgeries, and that sort of thing. The other piece that we do is we really consider the fact that many of the children are experiencing trauma when it comes to repeated medical procedures, not being in control of what's happening to their bodies, being arranged in positions that are uncomfortable, or being just subjected to long appointments or sedations where they wake up and they're uncomfortable. And so we really try to take that into account, because if someone is at a heightened level of anxiety or stress because of the trigger of medical environment, then they're going to perform differently on our test than if they had been really emotionally comfortable. So we have a bunch of different techniques that are sensitive for testing. A lot of those have been published. We're constantly updating those. And this is just a table listing a lot of them. So some of the things we do, it's really important that when we're testing children and young people and adults, is that we partner with them or with their families to understand what helps them. Just because they have MPS and we've worked with MPS doesn't mean that we automatically know what to do in that testing room to fit that person's specific needs. So for the MPS types or MPS individuals who have a lot of activity level, a heightened level of energy and low attention, we used to just sort of by design, follow them around the testing room, let them move freely, and just sort of not force them into anything and just bring the test to them. Then through our listening and talking with families, there were parents who said, you know what, my child needs physical boundaries, because you're never going to get my child to sit down and really engage in the test and show his or her best stuff if they're able to just sort of express themselves in that joy and get the movement in. So the boundaries are going to be really much more comforting. So those are the kinds of collaborations that we have in our clinic, and that I would really strongly encourage parents who are bringing their children to a testing setting, that you feel very empowered to say what sorts of techniques will help your child do their best, and show their skills. And then also, if you're the diagnosed person going in, make sure that you talk about those things. In the middle here, this sweetheart, we have sitting in the comfort of her mother's lap. We don't force separation by any stretch when we're in our clinic. And then this young man was much more comfortable to stand while he was testing. We also have a really rich child and family life program, and that's meant to really make it a comforting test setting. We have the highest level of trained facility dog who's very calm with the children and just makes it a much more comforting and non-clinical environment to bring about some really nice comfort. So when we think of all these things, what do we do to make sure that we're testing the whole person? We really think about the person, and we think about constantly keeping MPS on our minds. There's this other piece to this, which is we try very hard not to make it only about MPS. So let me just show you this to illustrate. I guess her sound isn't up, but she's taught, this is an unaffected child, and she's saying, wave bye-bye, wave bye-bye. And the person with the camera is the father. And he's saying, I'm going bye-bye, wave bye-bye to me, wave bye-bye. And you could, if his voice had been on here and if hers had, you can hear this frustration in the parents' voices, and you can almost hear from their voice tones, he can do this. If only we could capture his wave on this camera. And we see he's in the comfort of his home, in the comfort of his mother's arms, and she knows he knows how to do this. And he's not. And it's not because he has MPS, because he doesn't. And so we try to hold this sort of thing very close when we're testing kids. And we hold close not just the fact that sometimes during one of our sessions, we're not going to get them to do what we need them to do. We also hold that that's really hard for the parents to be watching and knowing in their heads, he can do this, he's just not. And we don't have to make that always about MPS. Maybe you know, there's an MPS profile where there's some refusal behaviors, but also we don't have to make every single thing that we see in our session about it. And we have to account for the fact that parents and family and caregivers are really important reporters to help us understand how somebody's doing. So when we expand the lens, there are many, many good reasons why, right? Because we want to make sure people are seen, they're seen as a whole. We really need to recognize the priorities of the child and family. It's also important when we think about research and trial inclusion. Traditionally, a lot of programs have been very focused, needed to be focused on the youngest affected people whose MPS has not accumulated enough to get to a point where the symptoms might not even respond to the most effective of therapies. So that has really narrowed the number of people who have had access to these clinical trials for the chance of a treatment. And then there's also, what about the individuals in the community who haven't necessarily been the target of a trial, who are still having a lot of unmet needs? There's a really important regulatory emphasis, obviously, on making sure that we are reflecting how patients feel and function and survive. So the feel and function piece here is really important when we're expanding this lens. Here are some of the incredible publications that have come out of the community that we're so grateful for. When we think about, you know, what are the experiences that matter to the community, that go well beyond IQ, when we think about change and what would be benefit. And here we have an incredible picture reminding us that caregivers are not just parents. Siblings have critical roles, and I'm going to show some of this wonderful young man's research soon. Okay, so thinking about some of the priorities the families have expressed, one is certainly communication. So there had been a natural history study of MPS 3A. This was the Shire study quite a while back. And there were a lot of data that needed to be mined from that study. That's something that is necessary in almost every study. There have been a lot of data that have been collected that continue to need to be mined and reported out. And here's one of them. So what we did was we looked at communication, which has been voiced by many people in the MPS community, that loss in communication and difficulty with connecting contributes to frustration. It contributes to frustration of the affected person and of the family trying to help them, contributes to behavior. And what we found was that the change in MPS 3A in that natural history study, the change in receptive communication, so how the children were listening, understanding, responding appropriately, that was nearly aligned with the change in the cognitive function. So it turned out to be a pretty good metric for examining change in the clinical disease over time, and is something that's really meaningful and requires sort of listening, engaging with the families. Certainly, if some of you are wondering, well, could the attention difficulties in Sanfilippo be a part? Absolutely. And knowing that attention can get harder over time in 3A, then it's reasonable that they're intertwined anyway when we look at this. On the other hand, the examination of gross motor change over time in this same natural history study showed that it really is not the best metric for that would be really sensitive to a rapid change over time. And does that mean to disregard gross motor? Absolutely not. Supporting gross motor function and pain is super important at the clinical level. Individuals need this supported and accommodated and considered. The thing is that gross motor function also gives really important insights to other aspects of MPS 3. And so I'll show this. We have to think about how the functions interact. So we see it, of course, when we're looking at how someone's performing on a test, we have these ideas in mind, but then when we actually analyze it over time, what we see is there's this pretty big discrepancy in loss in cognitive skills versus loss in motor, right? So gross motor is higher up, meaning that those skills tend to be preserved longer and functioning at a higher level than cognitive skills. And when we consider those two paired together, we think about the fact that safety, redirection, helping to support the children is sort of this disparate level of functioning where there's still physical capacity that's well above kind of cognitive and conceptual and anticipating dangers in the environment and taking redirection and holding that redirection is one of the pieces to understand the functioning and challenges in MPS 3A. Another really nice illustration of the interaction of functions, and this is by Nathan Grant when he was a research associate in our program. And I'll just expand this. He was the lead in a study examining two brothers with Hunter syndrome who were treated at different ages. So the green arrows up here, that's the brother who was diagnosed clinically and began treatment when he was 3 years, 8 months. And then the orange arrows down here are, that's the younger brother who was diagnosed because of his older brother. And I just want to highlight some pieces of this. So what we see is that there are differences in decline in sleep speaking. So the brother who was treated older became minimally verbal by age 6 years old, whereas the brother who was treated when he was younger, when he was 7 years old, he was still speaking at a 5-year-old level. When we then, speaking of this interaction of functions, when we then look at differences in behaviors, we see that the brother who had less verbal communication ability had more of the kind of neuronopathic Hunter profile of a lot of biting behaviors, running behaviors, very hyperactive and very physical toward other people. It doesn't mean that his younger brother didn't have that at all, but he was sort of less less significant in the intensity of his symptoms. We did some focus groups to understand the impact, really kind of getting at the behavioral priorities in Hunter syndrome. Here are some of the things we found. Certainly there's a family impact. There's also an isolating impact and just sort of a challenge with quality of life when there are barriers to accessing kind of the freedoms and engagements of a child who isn't experiencing these highly significant behavioral symptoms. So the other thing that I had pointed out is the research and trial inclusion when we think about why we're expanding the lens. And this graph shows kind of that the trials that have been focused on this kind of more narrow segment have therefore meant that more than 99% of the MPS 3 community has not been included in trials. A lot of the trials for quite some time were 48 months and younger. In more recent years, we know that got even younger for access to trials, and that really left a lot of that community and a lot of other MPS types without a chance at trying for treatment in a trial. I won't go too deeply into the details in this because Dr. Polgreen obviously did a really nice job describing her study. It was a privilege to be a part of this study. And one of the things that was so meaningful was the fact that this study was really focused on these other aspects of MPS and really expanded the lens in a very deliberate way. And I loved that we partnered with Kara O'Neill from Cure Sanfilippo to help make sure that the community was represented every step of the way in terms of those needs. So the SBRS, or the Sanfilippo Behavior Rating Scale, has a number of domains that represent a lot of the heterogeneity of the neurobehavioral profile in MPS 3. And something that Dr. Polgreen had pointed out is during this trial, I have the treatment period highlighted in blue. What's really important is that we see this sort of kind of like a U shape where reduction in symptoms, so good is down. And so during the trial period, we saw that there was a reduction in symptoms, and this period at the end of rebound was critically important because there were a lot of people who wondered, well, you haven't really reported the natural history on the SBRS as plentifully as you have cognitive, for example. So how do we know that this reduction isn't just disease progression? And so this rebound, when coming off of anakinra, just sort of increased our belief that anakinra had been related to this reduction in the symptoms. I also want to point out some lessons learned from this trial. Certainly the power of the community voices. The trial was designed in partnership with Cure Sanfilippo Foundation, but then also by using the published literature from the community about what mattered the most to them. We also learned that it's going to be really important because you don't know what you don't know. And no matter how hard we tried in that partnership to come up with what are all the instruments and tools that could possibly capture these priorities and see whether they're being touched by this trial. You can never plan for the potential unexpected benefits. There were some that families reported that were incredibly exciting and hopeful, but because we didn't have in that phase 1-2, we didn't have a systematic way to gather it. It really would have been, it's not really good science to just sort of cherry pick really great stories as much as you really are just so enthusiastic for the families. But so we're going to try very hard to make a lot of deliberate space for that. And that's something that FDA is really interested in, is those interviews to hear from families how they're experiencing the trial. The other piece that's really important for research and trial inclusion is that there are individuals whose MPS doesn't involve cognitive challenges and doesn't involve decline, and yet there are still a lot of unmet needs. walking you through this. On the left, we've got MPS 1. I'm trying to get my pointer. Here we go. That work? No. Oops. Okay. So on the left, we have MPS 1, and my pointer has stopped working, so that's fun. So the uprights that are shaded in sort of maroon on the right, that's the average range. If you go to the left of that, that means you're below the average range. And there are several domains here that look at things like being able to hold information in your mind and work with it and kind of spit it back out. So somebody who has a challenge in that area might walk into a room and say, wait, why did I come in here? Now we all experience that, but it turns out that people with the non-neuronopathic MPS 1 experience it more often than people who don't. So there are a variety of challenges when it comes to different ways of thinking in MPS 1, short-term memory, and rapid strategic problem solving. Non-neuronopathic MPS 2 has consistently shown below average attention spans, even when there's sort of average cognitive abilities. Also some challenges in quality of life in terms of physical functioning. We have a study going on right now. If anyone would like to participate, this is if you have an MPS type that does not classically have a rapid decline. And we're comparing cognitive scores with scores on other kinds of tests to really quantify that there are measurable unmet needs in a lot of the non-neuronopathic and/or attenuated forms. So this is an area that really needs more attention and ideally therapies to help with these challenges that can create limits to someone sort of fulfilling their, living to their cognitive level. The last piece I'll bring up is that there are emotional symptoms that a lot of individuals with MPS experience with the trauma of kind of the repeated medical journey, community exclusion, and difficulties with MPS and sort of the not knowing what. But then we also think that there are emotional symptoms and psychiatric symptoms that occur aligned with either genotype or with different MPS profiles. And so we're really starting to investigate this to understand this piece better. I'll move past my summary slide in the interest of time. I just want to say thank you so much to so many people who I work with and learn from. Number one is the community. Thank you.